So today, we're going to speak about sleep disorders in Parkinson's disease. And we all know how important sleep is. Probably some of you will start nodding off in the middle of this talk. It's not unusual. I see, especially was evident in medical students, you always see them with this whiplash with their nodding off during a lecture. But sleep is so critical for life. It's where everything is rebalanced, everything recharged. And the whole process of sleep is very complicated. It's still not completely understood. What isn't completely understood is really on many levels. We know that if you prevent animals from sleeping, I'll tell you how critical it is. There are experiments with rats where the rats were not allowed to sleep. They had electrodes on their brain, and whenever they had to slow wave sleep, just as they're falling asleep, they were woken up. Not allowed to get into slow wave sleep, which is the deep restorative sleep. And what happens after days and days of no sleep, the animal's body temperature begins to go below the ambient temperature. And they eventually die of hypothermia. They can eat, they can do everything except sleep. And one of the first homeostatic mechanisms is the thermostat. The first thing that'll go, and when it gradually gets below a certain level that sustains life, the animals will die. A warm-blooded animal will die. If you lower body temperature in an animal that doesn't regulate constant body temperature, they go into hibernation. So you can get a frog or a lizard that'll sleep for a year. And as you bring the temperature up, they come alive again. So sleep is somehow related to our setting of temperature in our thermostat. So that's one of the fundamental mechanisms that's involved in sleep, resetting this diurnal rhythm. Now, what is a diurnal rhythm? Well, when there's a lot of light, we become very, very active. When there's no light, we sleep. Now, the diurnal rhythm varies across species. In a mouse, it's just the opposite. Put on the lights and the animals sleep. Turn off the lights and they become active. So diurnal rhythms are biological clocks that allow us to adapt as the Earth spins on its axis. And that's one day. One spin, 24 hours, time to spin around on an axis. So some of the human research with sleep took place that was really critical at my alma mater, the University of Chicago, before my time. I mean, this was in the early 50s. Rexhoff and a number of colleagues had developed a first sleep lab where they would hook people up, bring them into a special room in the psychology department, like a little hotel room, but they would wire them up with surface electrodes over their eyes and below so they could track eye movements, respiratory rate, heart rate, and oxygen saturation. You can imagine that it would be hard to sleep with all that, but people would adjust. In their early experiments, they used college volunteers. And they just want to see what happens during normal sleep. And so a lot of the, quote, sleep architecture is a strange term because think of a three-dimensional structure which you go in and out of, But the three-dimensional structure of sleep is really a four-dimensional structure, or maybe infinite dimension. Because what happens when you're asleep? What is the dimension? Well, all these neural activities are going on in 3 dimensions of the brain over time, so there's a time element. And there's dreaming, and then altered states, where you feel that you travel in other planets. You talk with your dead ancestors. All this can happen while you're dreaming. It's quite amazing. Because we have these alterations of consciousness every 24 hours, where you can lose consciousness, you get deeper and deeper and you're unresponsive, and then you gradually, what was learned in Chicago was that as you gradually come into faster and faster brainwave activity, I should specify that if you put surface electrodes throughout your scalp, the electrical activity that's detected is very fast, and you don't see any big waves. You see it's like a jittery, super active waking electroencephalogram. So brainwave activity is fast frequency, low amplitude, everywhere they look. When you go to sleep, initially your waves get to about 13 cycles per second, especially back here. Those are the waves that are turned on when you close your eyes and just try to think of nothing. Then your electrical activity slows down. You're perhaps in a meditative state. If you're then actually going into sleep, the brainwave activity gets from 12 to 8 to 3, and finally in deepest sleep, it's about 2 to 3 cycles per second, just slow wave. And that's called slow wave sleep. It's the really restful, restorative sleep. You're completely unconscious of what's going on when you're in slow wave sleep. And if you had any movement disorder, it's gone when you're in slow wave sleep. So if you had tremor, if you're in slow wave sleep, it's gone. If you had rigidity, it's gone in slow wave sleep. So it's very important for people with Parkinson's disease to get into a deep sleep, and that's one of the things, that the sleep cycle, the sleep architecture is disrupted and deranged. As we age, it begins to happen, but it's very deranged in Parkinson's disease. But I'll finish the description of the normal sleep cycle before I talk about what we're noticing about Parkinson's disease. So that's slow wave sleep, 2 to 3 cycles per second. You can see on an oscilloscope or on a printout, if you take that electrical activity, transduce it into an operating of a needle, you'll see 1 per second. It's a wave. Start speeding up as time goes on, so by around 80 to 90 minutes after you hit the sac and you've been into slow wave sleep within a half hour to 45, you start getting faster wave sleep until finally you have what looks like normal waking activity, but the patient is not awake. The thing that happens then is that the eyes are moving. They detected fluttering of the lids and the eyes are moving in all directions. And people are tonically paralyzed, they're immobile. That is called rapid eye movement sleep. And that occurs 90 minutes after you've fallen asleep and just before you're ready to wake up. And they noted in these early studies that they shook someone when they're having that rapid eye movement sleep, they would immediately go into detail about what they were dreaming in great detail. But if you woke them up with slow wave sleep, they have no memory. And it was harder to wake them up. Easy to wake up someone who's already electroencephalographically awake, the brainwave activity. And that's why what the person is experiencing during sleep, it's like conscious everyday activity, but he has no way to verify it, or she, because she's paralyzed. How do you verify what's happening in your head? You see people, you're back in a battle in Vietnam or whatever. How can you verify it if you're paralyzed? You can't. So you may have the dream, and that's a big problem in Parkinson's disease, is that part of the sleep architecture we'll get into. Then, if you don't wake up, and most people don't wake up in the first cycle, they should enter again, another cycle. Every 90 minutes you go slow wave sleep. And usually you only remember the last REM sleep episode just before you wake up in the morning. That's why most people, if they're going to remember their dreams, they have at least 4 to 6 episodes when they could be dreaming, but they'll usually only remember the one just before they wake up, or if they have to be woken up at the time that they're having that dream, if someone wakes them up accidentally. So that's the nature of sleep. The purpose we don't understand. The neural circuitry involved is very complex. It involves brainstem projections of serotonin neurons in the brainstem raphe throughout the whole cerebral cortex. And the serotonin system is very much involved in sleep-wakefulness cycles. The norepinephrine, which is downstream product of dopamine, it's a very important neurotransmitter, is very much involved in dreaming activity. And other neurotransmitters are involved in mediating various aspects of sleeping and dreaming. And needless to say, in Parkinson's disease, everyone knows that the dopamine neurons are lost. They're involved to some degree in the sleep cycle, but the loss of serotonin neurons, the loss of noradrenergic neurons, plus dopamine neurons results in disturbances, not just in motor control, or mood or thinking, but in sleep regulation. Therefore, you should not be surprised if anyone ever knew about this or haven't experienced it, that sleep in a Parkinson's patient is not optimal. In fact, between 50 to 98% of all Parkinson's patients, depending on who did the study and how large the study was, have a sleep disorder. Well, now, there are many kinds of sleep disorders. The most common thing that people notice in Parkinson's disease has to do with the fragmented sleep. Oftentimes, it isn't difficulty getting to sleep. They get to sleep pretty quickly, quite often. It depends on the studies. But then they wake up many times throughout the night. They never really have restful sleep. So it's a sleep fragmentation with multiple awakenings. Many patients say, well, I have to get up to urinate. That's why I wake up all the time. And in part, that could be one of the reasons. But there's an underlying problem with the sleep cycle that results in them never getting into the deepest sleep, never having a normal transition between cycles. So they feel that their sleep isn't that restful because they never really spend enough time in slow wave sleep. The other thing that happens is that the REM sleep doesn't occur in the normal way. Remember when REM sleep, rapid eye movement sleep, translates into dream sleep. That's when you have your dreams. Just a few minutes. Your 2 minutes of dreaming can seem like a whole epic movie that you've seen. It's quite amazing that's why I say, what is the architecture of sleep? Well, architecture, you think about three-dimensional structures. But sleep and consciousness is multi-dimensional. Yeah, there's 3 dimensions of the structure of the brain, but there's this element of time and the perception of time that's quite difficult to grasp. And that's some of the mystery of sleep and consciousness. Notions of infinity and going on forever, the vastness of space, the vastness of inner space, etc. Now I get kind of philosophical. But so let's talk about the biggest, one of the most troubling parts of sleep disorder besides the fragmented sleep, which we can do things about. And I'm going to have at the end how we manage sleep disorders with sleep hygiene and pharmacotherapy or medications. So the REM behavior sleep disorder is very, very common and often antedates Parkinson's disease diagnosis. Before any tremors, slowness, or rigidity is ever seen, people will notice, and the caregivers or spouses are the ones that notice it more than the person themselves, acting out, yelling out, vocalization, fighting imaginary things, having nightmares. That means that you're having your sleep, your dream sleep, without the tonic muscle inhibition. This is a really important part that I have to emphasize. When healthy people dream, they have a very active processes going on, just like they're awake. And their eyes are fluttering, looking at things that are happening in their internal scenes. But they can't move. There's a tonic paralysis. It's kind of the strike. There's a downward inhibition of all motor movement. And that's why you don't act out your dreams. That's why you can't yell out in your sleep. But if that inhibition of movement occurs during your REM period, it doesn't occur, that blocking of movement, then you have REM behavior sleep disorder. And when you think of it, well, there is a problem about the control of movement in Parkinson's disease. It's kind of just the opposite thing happens in REM sleep. You have too much movement because you're not inhibiting it properly. In fact, there's a lot of, I'm not going to get into what I think is the mechanism for all of this loss of inhibition of tonic, loss of inhibition of the motor outflow. That's what happens normally. What happens in Parkinson's. Let me just say it again, because it's when you remove an inhibitory influences, you get activity, right? You take your foot off the brake, the car goes forward, right? Many cars, anyway, they have a foot. So the idea is if you remove the inhibition of motor output, you're going to move in the middle of the night, and that process is what's happening in Huntington's and Parkinson's disease. The other thing that happens is, and this is more likely to happen if people have a mild cognitive decline. All of these things I've described happen in people with normal intellectual function who have Parkinson's disease or even before. They have REM behavior sleep disorder, they have fragmented sleep, multiple awakenings. The the interesting thing is that, well, I don't want to get too hung up on the REM behavior stuff, because that's actually the most difficult. There's something that is confused for REM behavior sleep disorder called Restless Leg Syndrome. It's confused because people are moving their legs as they're trying to sleep. Well, REM behavior sleep disorder is characterized by thrashing about, moving of legs, but it's completely unconscious. When you have restless leg disorder, it happens as you're trying to sleep, or it can happen if you're sitting for any length of time. You have this discomfort in the limbs, and you need to move to get comfortable. So it's this response to the feeling of some discomfort in the legs. And restless leg syndrome occurs independent of Parkinson's disease. It can occur in people who have neuropathies or lower back issues, but it's very common in people who have an iron deficiency. So we'll check for serum iron, and it's treated by iron replacement, but also with low-dose dopamine drugs, like Requip, just at bedtime. So that's called restless leg syndrome. It's not really a sleep disorder, but it can interfere with falling asleep because of the discomfort one feels. And that's usually managed, this one I'll tell you how I manage it, it's pretty straightforward. If it's restless leg syndrome, it's usually noted as you first go to bed to lie down and you feel a discomfort, you're kind of trying to get comfortable. But when it's really bad, it can happen during the day too, and sometimes you need to take a little bit more dopamine replacement. What's interesting is there the question that was raised when restless leg syndrome was being really discussed a lot, what's relationship to Parkinson's disease? Because in both situations, dopamine replacement improved the illness. And because you have restless leg syndrome doesn't mean that you will develop Parkinson's disease. And restless leg syndrome, as I said, is seen in many other conditions besides Parkinson's disease, and it's a minor part of Parkinson's disease. Most of the discomfort people have in Parkinson's disease as they're trying to go to sleep has to do with the fact that their anti-Parkinson medicine is not working around that period of time, so they're more rigid and uncomfortable, and they're not moving, they're complaining that they can't move. Unlike the restless leg syndrome where they're constantly shifting their position, because they don't need to have Parkinson's disease, but the factor that interferes with falling asleep in Parkinson's disease is Parkinson's disease itself, because of the rigidity and the discomfort and difficulty initiating movement and shifting body weight results in difficulty falling asleep. Other aspects that can be associated with insomnia or difficulty with sleep is depression. And depression goes hand in glove with Parkinson's disease. Neurotransmitter systems are diminished, like serotonin and norepinephrine. And the drugs we use to improve depression raise those. So when one is depressed, it often manifests as problems with sleep, either excessive sleepiness all the time or not being able to sleep, changes in appetite. Oftentimes, when we treat the depression, the sleep improves. So all of my patients, when they have insomnia, depression, and Parkinson's disease, I don't whip out the prescription pad for benzodiazepines. I'm going to get into this very soon about what drugs to avoid if you have chronic insomnia versus drugs to use for just a short period of insomnia. But basically, what really should not be used would be benzodiazepines unless it's only for a week. In other words, that is Ativan, lorazepam, clonazepam. They all worsen depression. And the ability to induce sleep ceases after a while. And you become dependent and have a withdrawal syndrome and you go to stop it unless you gradually taper it. So I rarely will prescribe any of the benzodiazepines. They're the Valium, Librium family that have been evolved and modified to last a little bit longer to serve as sleeping agents. I'll tell you about some of them that could be useful in terms of medications to improve sleep. The other aspect of sleep disorder, another component of sleep disorder, is what you would imagine. If you're not sleeping well at night and not getting restful sleep, you're going to be sleepy all throughout the day. So they have multiple naps throughout the day and daytime somnolence. And some of that is part of the disease process, the sleep disorder associated with Parkinson's disease and depression. But part of it is the fact that the daytime somnolence is due to the medications one uses. Because I already told you that it's part of the disease to have daytime somnolence. It's associated with poor sleep at night. But some people's daytime somnolence can come on really quickly, called sleep attacks. And the drug that was notorious for that, and still you have to be careful with, is Mirapex or pramipexole. People were known to be driving, they had mild Parkinson's disease, they take Mirapex and at the stop sign they fall asleep. People have to honk the horn wildly to wake them up. And so that was happening very often. And so everyone who's given Mirapex, aside from the idea that it can make you a gambler, a womanizer, and fall asleep at the wheel, that's all the reasons to be careful about Mirapex. But we have to start using it at a very low dose. And it turns out that other dopamine agonists, remember what a dopamine agonist is? It's a drug that acts like dopamine. Levodopa is the natural raw material for making dopamine. That's what levodopa-carbidopa does, is elevate the synthesis of dopamine. But we use direct-acting dopamine agonists, so Mirapex, Requip, and rotigotine or the patch. Those are the three we most often use. All of them can make you a little bit drowsy. Even levodopa-carbidopa. People will often say, when I take it, I have this period for the first half hour, 45 minutes, maybe an hour. I feel a little drowsy, and then once that's over, then I'm active. It doesn't happen with everybody, but it's not an unusual response. Feel a little bit tired, low energy when you take your anti-Parkinson. However, that made a lot better if you really sleep deeply at night. Then the anti-Parkinson medicines won't make you so sleepy in the day. Better sleep hygiene. And that's the first thing that we have to work with before we start writing prescriptions and adding more medications. So, and sleep hygiene is really terrible in our day and age because we have lights on at night, we have the TVs on at night, and that resets our diurnal rhythm, which is regulated by how much light gets into our retina, which then goes to the pineal gland that makes melatonin. So when you have light on, melatonin production, which triggers sleep, is diminished. And as we get older, the amount of melatonin that we make diminishes naturally. So if you're trying to get to sleep, you should really, let me read you some good sleep hygiene. Regular rise time and bedtime. Do this every day. You can help your internal clock by providing regular cues. So if you stick to a rhythm, get up early when the sun is up and go to bed early once it's dark. Don't go to bed when it's light. Don't get up while it's still dark. You're not a farmer anymore, right? You need some rest. Get plenty of bright, natural light exposure in the day, preferably in the morning, along with exercise in the morning. Don't do the exercise in the evening. This will give your internal clock a strong cue to run on time. So that bright light, so many people that live in Florida will have all their blinds shut, air conditioning up, and not let the sun in because they want to keep the house cool. So it's kind of dark. And at night, they put on the lights so they can navigate and see so they don't fall. So they never get the bright light of the day and the darkness of night to reset their biological clock. So plenty of bright light in the day. If not, some days we do have gray days, but the nice thing about living in Florida, it should be easier to entrain our rhythms because we have such good light. And it's probably why a lot of people come down to Florida, because first of all, the warm temperature is good for the rigidity. There's less rigidity. There's less ice and snow to fall on. And bright light in the day is really excellent for setting your biological clock and serving as an antidepressant, by the way. Avoid stimulants, and that is in the form of coffee or tea or nicotine. Avoid those kinds of drinks, which are Coca-Cola, Pepsi-Cola, and avoid those caffeine-containing beverages 8 hours before you go to bed. So if you go to bed at 10, 4 o'clock, don't have any stimulant after 3 or 4 in the afternoon. Try not to think about topics that cause anxiety, anger, and frustration. Yeah, sure. Well, don't turn on the TV, don't listen to the politicians, etc. At this time of the year, it's entertaining. People are not going to do that. This is what they threw in. I'm just telling you what some experts tell us to do. Maintain a definite bedtime routine that's relaxing to help signal the body that sleep is soon to occur. So it's basically a ritual routine like we do when we get up and then we go to bed. It's very important. And so some examples, you may want to take a bath, or you may want to brush your teeth, a glass of warm milk, 4 to 6 ounces, a lot of people will take. I'm always saying don't drink milk when you take cinnamon, but at bedtime it's good with a little bit of honey and milk, warm milk, releases serotonin, and that helps induce sleep. It's an old wives' tale and it works. Reserve the bedroom, and especially the bed, for sleeping. Avoid activities like reading and watching television in bed. If you nap, try to do it at the same time every day, no more than 1 hour, ending by 3 p.m. So it's okay to take a nap, but don't do it for longer than an hour. Staying asleep. So this is just to get to sleep. Staying asleep is minimize light, minimize noise throughout the night. Avoid heavy exercise within 6 hours of bedtime. Exercise increases the body temperature. Sleep onset normally occurs as the core body temperature is decreasing. And if you don't sleep, your core body temperature will never recover. But no one is ever subjected to such intense experimentation as those poor rodents. Avoid heavy late night meals. Moving in bed. This is one of the things that interferes with patients. They're in more advanced stages, they're rigid. It's difficult to initiate a movement, especially turning in bed. Some of the tricks that are recommended is use of satin sheets on the bed. They're very slippery to help, or satin pajamas to help with, not only is it glamorous, it allows you to be sleek in bed. And by being able to shift positions during the night, sometimes on your one side, sometimes on your other side, sometimes on your back, you're going to have less stiffness and pain in your joints when you get up in the morning. So having some mobility during the night is good. This is one of the reasons I like the Nupro patch, which works 24 hours a day. And I can just jump ahead to one of the reports where they studied Nupro in terms of sleep. Now, many of my patients take this dopamine agonist that's once a day. And one of the first findings that was noted is that people who were on this slept better. Because they have the constant dopamine action, they don't get as rigid and they can move a little better during the night. And when they wake up, they're on already. Not 100% on, because they still need some levodopa, carbidopa. So that one is a good one to take to maintain mobility at night. Or a controlled release agonist or a controlled release levodopa. Waking to go to the bathroom is always one of the big issues, right? So the thing that's recommended is drink the evening fluids. Take less of the evening fluids in volume, 3 to 4 hours before bedtime. So 3 to 4 hours before you go to bed, try not to drink fluids, minimum amount that you need, maybe a little bit for your bedtime medication. This will lessen the chances that you have to get up to use the bathroom. Make sure you drink plenty of fluids in the morning hours, however. Make up, because you do need plenty of fluids. If you often get dizzy when you stand, sit at the side of the bed for a moment while flexing your leg muscles before you stand up. And in those situations, you really need to perhaps increase the salt intake or drink Gatorade. When you're dizzy when you stand up, it means your blood pressure is dropping. It usually means you need more blood volume or salty fluids in your system. One of the ways that you can be proactive about your sleep hygiene is to keep a diary of your sleep. And then if that's a big issue, if sleep is a major issue, there's other sleep things that happen in Parkinson called sleep apnea. And that can only be ascertained by doing polysomnogram studies, sleep studies. So people who have really a very severe sleep disorder, not just some sleep issues, because everybody with Parkinson's disease has a sleep issue, I would order a sleep study. And part of the sleep study is they give you a sleep diary that before you go into the study, when you sleep in the facility overnight, maybe 2 nights, and it's a very interesting just thing that they mention. For each day, you'll have, what time did you turn off the lights? How long did it take to fall asleep? How many times did you wake up? What time did you wake up in the morning? What time, and do that for every day, and you'll look for patterns. And this is for the study. Now, we'll get into this treatment. First thing is sleep hygiene. And we've gone over that. However, one of the most common things I do, because of the association of depression with sleep disorders, is use an antidepressant. And there are two kinds of antidepressants that could be used. The ones that I like to use are ones that cannot be taken in the day because they make you extremely somnolent. So they're ideally, that side effect will limit its daytime use, makes it ideal for bedtime. There are two drugs that we use for that. One is called mirtazapine, or Remeron, which really is fantastic for inducing sleep. And the duration of sleep benefit, of sustained sleep is much better than without it, of course. And also the mood improves within a month. You have more energy in the day. The other one is trazodone, so Remeron and trazodone. Trazodone is preferred by women who are afraid of gaining weight, but the mirtazapine people have an increase in appetite and put on some weight. But a lot of my patients are losing weight and depressed and a sleep disorder, so mirtazapine is ideal for that. Other antidepressants are called the Tricyclics, the original class of antidepressants, before the newer ones like clonazepam, Valium, Ativan, those kind of drugs. Before those, there was the Tricyclics, amitriptyline. They're very sedating. They have some mild anticholinergic effects, which is good if you have tremor and the tremor is bothering you at night. Well, that's a great antidepressant to take at night. It improves sleep, it helps the tremor. Side effect is it can give you more dry mouth. Almost most of the medicines we use that affect the nervous system have as a side effect a dry mouth. And then giving a long-acting dopamine medication at bedtime can help. So first is the antidepressants, just try to get improvement with help. Second would be the making sure that the antidepressant medicines, the anti-Parkinson medicines are given at just before bedtime if the problem with getting to sleep is the Parkinsonism. They're very rigid and slow, they can't turn. You want to give them a bit of the medication to relieve slowness and rigidity. To decrease the need to get up to the bathroom throughout, to urinate, sometimes we'll use Ditropan or Vesicare to inhibit the bladder slightly so there's less urge to get up. You can get up less frequently with that medication. So there is two interesting things that I've read about more recently that intrigued me. One is the use of melatonin for REM behavior sleep disorder. And there's a paper that was published. It's not a great paper, but I thought I'd read it to you. Melatonin for treatment of REM sleep disorder in 14 patients. So it's not a classic double-blind study with placebo, but it's very promising because they took it for a year. And there's a sleep rating scale, and the majority of those patients had improved sleep that was sustained by taking at bedtime anywhere between 3 and 12 milligrams of melatonin at bedtime. So that's a good one to start using because it's an over-the-counter. And then there's a drug that is available by prescription that is mimics melatonin, but it has a much longer duration of action. It's called Rorazem. And I've never really begun to use it until I began to study how it worked. They say it works differently than all the other sleeping pills because it works on the melatonin system. Remember what I told you about melatonin? When it starts getting dark, your retina sees less light. There's a direct connection of the retina to the third eye, which is the pineal gland, which is actually, let me backtrack about evolution. Do you know that there is a creature with a vestigial third eye? It's called the lamprey eel. And the eyes are on the side, but on the back, very near the surface, you have a slight indentation. And there's what used to be in the eye, a third eye, that is sensitive to light, gets through the skin. It's like a light transducer, just like eyes are light transducers. It takes electromagnetic energy in the light spectrum and translates it into electrical activity, into chemical activity, and you see things. It recaptures what's out there. It's a light transduction system. The third eye does that too. And we've kept that third eye, but it doesn't have outlet to the top of it, which is good. We don't need to look up. We're not swimming like that. But we are like this, and branches of each of the optic nerves go to the pineal gland, which looks like a vestigial eye. It's really cool. And that's where melatonin is made. So it's transduced by the amount of light getting into your vision, without, even if you're blind. Light is getting through there, provided you don't have such opaque cataracts. But even then, you get the light in there, it triggers, if there's light at bright intensity, inhibition of an enzyme that regulates melatonin production. And this happens depending on light. It's constantly adjusted, like turning up the volume or down on melatonin. If you have darkness, the inhibition is removed and the melatonin levels begin to rise very quickly. Turn on the TV and you shut off the melatonin. So, yeah, after reading this very carefully, I realized that I can't watch the news on TV real late. So now I have the audio books now, just so I don't have to turn on the light. And mostly it's for my wife, because I sleep, every medical student sleeps like a log, because we were so deprived of sleep in our training that any moment my head hits the pillow, I'm into deep sleep. So I don't need that, but so that my wife was very sensitive to light. Then she complains of insomnia. Now she's sleeping better with audiobooks or music. So let's say melatonin works, but it only works so you sleep really 3 hours, then you wake up at 3 in the morning, and then what? Well, I would use an antidepressant plus melatonin. That should work better. Now melatonin is not working, even with the antidepressant. Well, I would try this melatonin receptor agonist. Remember what agonist means? It acts like melatonin. And Rorazem is a chemical structure, a new drug, relatively new, that binds with the melatonin receptor and triggers the induction of sleep, but it lasts longer, it's metabolized much slower than melatonin, and therefore you can get more long sleep. So that's the other. Side effects, people say, is it can worsen depression, just like a benzodiazepine, like Valium, Librium, clonazepam. And people can feel a little groggy the next day, but usually that can be adjusted by decreasing the dosage, and tolerance develops that effect. Then we have a series of benzodiazepines. The one that is most commonly used for sleep is clonazepam. And there are papers that show that it's effective in REM behavior sleep disorder. So most of patients who come to my clinic who have been diagnosed with REM behavior sleep disorder and Parkinson's are taking clonazepam at bedtime. And if it's a low dose, it's okay. But if you're going to take it for the rest of your life, it's not going to be okay. And REM behavior sleep disorder is permanent. It only gets better if you treat it properly. And clonazepam will work for a while and then will lose its effectiveness. And then you're physically dependent on it. So one of the alternatives that we use is Seroquel, which is a major tranquilizer that's different than the classical tranquilizers, and it has no negative impact on Parkinson's disease. Major tranquilizers block dopamine receptors. And so that's how we learned about dopamine being involved. You've heard me talk about this ad nauseum. In fact, dopamine makes you nauseous. But if you give a major tranquilizer to people, those drugs make you Parkinsonian if you take too much. They make you slow and rigid because they work by blocking dopamine receptors in the substantia nigra striatal system, and they block the emotional dopamine too, so people lose their crazy thoughts and psychosis. But Seroquel was developed as a novel tranquilizer that has no action on the motor dopamine system. It works on a subtype of serotonin system that's associated with hallucinations, etc. If you block that, you treat psychosis. But what we found is that it corrects sleep architecture. I began to use it for people, my patients who had hallucinations. That's how I began to use it. We noticed that their sleep improved dramatically, and they didn't have nightmares either. And they no longer had the REM behavior problem. Their hallucinations went away and they could sleep well. So I began to use it for people that just had really bad sleep, even without REM behavior disorder. And at the tiny doses, it works beautifully. Now, what is tiny? For a schizophrenic, you need 900 milligrams a day, 300 milligrams 3 times a day. In a Parkinson patient for sleep, 25 milligrams at bedtime. See the difference between 25 and 900. So it's a fairly benign drug, although the FDA makes you say, people who take this drug who are elderly and demented have a higher risk of death. Well, yeah, if you're going to treat it like a young schizophrenic at 900 milligrams a day, that's insane. Or if you have a nursing home patient who's aggressive and violent, and you just load them up with that, that's very bad. However, if you have a Parkinson patient, even if they have mild dementia, who's hallucinating, they have dementia with Lewy bodies, you can take 100, 200 milligrams of that at night and have no risk of death. I've never had any adverse effects with that drug. So, and finally, I think I covered it. I mean, most of my patients that complain of sleep will be on an antidepressant at night, perhaps a sustained acting dopamine agonist, and perhaps Seroquel with the antidepressant, low dose Seroquel. And that will ensure that they sleep. Then there's one thing that I rarely do that my colleagues like to do. People that are sleeping well, but they still have daytime somnolence, and it's really bad because they're still working and they just are too tired, and you try lowering their anti-Parkinson drugs, and then, yeah, they're more awake, but then they don't move as well. So I have colleagues who like using Nuvigil or Provigil. These are stimulant drugs that you use for narcolepsy. It's approved by the FDA for narcolepsy, which is a condition where there's sudden falling asleep episodes. And that's how it's approved. But people will use it for sleep attacks that we have in Parkinson's disease. First thing I would do with this about a person who suddenly falls asleep is get them off the Mirapex, because that's most likely the reason. And then if they're still having a lot of sleep issues, I'd have a sleep study. And at a certain point, if the sleep physiologist suggests that the stimulant would be a good one to give in the day, then we do. Because the stimulants can exacerbate paranoia, a thought disorder. You remember that one of the first drugs that was used for Parkinson's disease in Hitler's case, Hitler had Parkinson's disease, was amphetamines, and I think that made him crazy. Amphetamines will work to release dopamine and norepinephrine, make you feel you can move well, make you feel strong, and it works in Parkinson's disease while it's not too advanced. You still have to have enough dopamine for amphetamine to work, but later on, it's just going to make you crazy. Well, you'll see helicopters that aren't there. You'll see strangers coming from your past to collect their debt, whatever. So yeah, so I don't like psychomotor stimulants for Parkinson's disease, though they can be written as Nuvigil or Provigil or modafinil. These are stimulants that also not only for narcoleptic patients, but for people with attention deficit hyperactivity disorder, so children who can't focus and are hyperactive. These drugs have a paradoxical effect to allow them to focus. If you give these drugs to adults and they become overactive, motorically and psychologically, and thoughts just flow, which people like it because they get delusions of grandeur, feeling like they know everything, they can solve every deal. Sounds familiar, doesn't it?
Yeah.
But I'm going to end here. Oh, there's one question someone put up here, which is timely and appropriate. It asks, sundowning. Could you please discuss sundowners? Yeah. Well, what it is that when especially noted when a patient is in a hospital setting, usually older patients, really typically there has to be some dementia there. Very mild cognitive impairment or frank Alzheimer's disease or some serious cognitive issues. Those patients put in a strange environment are okay in the day, but as soon as the sun goes down, the evening comes on, they get very disoriented. They don't know where they are. They're often disoriented anyway, but then they're reminded in the day they're in the hospital, etc. They get very disoriented, agitated, confused, and try to run away and get themselves in trouble. So that's a sundowning, and can occur in Parkinson patients who usually in a nursing home. It would happen in the evening. If they're patients with Parkinson's disease in a nursing home are there for two major reasons. One is because of their cognitive decline, and it becomes very difficult to take care of them. They need help with all activities. Patients with Parkinson's disease with cognitive decline end up having sundowning episodes. The only thing to do is reassure them, and after a while it'll disappear. It's usually a phenomenon that happens in a new situation. The worst thing to do is to bring in tranquilizers when someone's having a sundowning episode. They need reassurance from the caregiver who visits or the nursing staff. And the thing to avoid is though it can be done, if there is low doses of the novel tranquilizer like Seroquel, given around supper time, would alleviate the anxiety that they feel when they realize they're in a strange situation. Yeah, they don't recognize people, they get confused. So sundowning is a delirious confusional state that occurs in strange environments, relatively strange, in patients with cognitive decline. And some patients with Parkinson's disease have that, some don't. Depends on whether they have the cognitive decline. So that's it. I'm going to end it here. Thank you. Have a good night's sleep tonight.